Hello guys, I have recorded this lecture but it had no sound, so now I'm recording the sound again. And the topic of today is the hypnotic drugs, antiparkinsonian drugs and anti-epilepsy. So firstly, what is the sleep? Sleep is an active circadian physiological depression of consciousness. And normally in physiological condition, we have two phases, the slow wave sleep and the rapid eye movement sleep. In the slow wave sleep, we have slow movement of eyeballs, and it has the slow wave in the EEG, electroencephalogram. In the rapid eye movement sleep, we have the fast waves or paradoxal electroencephalogram. Talking about the use of this information in our everyday life, it can be used for you to know how to sleep well. Because, for example, if you wake up during the slow wave sleep, you feel very bad. And if you wake up during the rapid eye movement sleep, you feel alert and fine. So I always recommend you to remember that in our normal sleep, these phases, they go one by one. And the slow wave sleep will be changed every 1.5 hours with the rapid eye movement sleep. So I recommend you to sleep according to that, to that information. If you sleep 1.5 hours, so after this time, in the next 20-30 minutes, you have to wake up, because this waking up in the rapid eye movement sleep will be much better and much easier for you. So this happens during the whole night. And for example, if you have 3 hours to sleep, yes, you have 1.5 hours, then 20-30 minutes of rapid eye movement sleep, then you sleep again 1.5 hours, and only after that you have to set on your alarm clock to wake up. So it will be the best way to wake up alert and enthusiastic. Okay, so let's move on, I think. When people have problems with the sleep, we call such condition the insomnia. There are clinical variants of insomnia. First, it's the presomnic insomnia. In that case, patients have difficulties in falling asleep more than 30 minutes. In intrasomnic, patients fall asleep early and wakes up early. Also, he can wake up several times at night, or maybe he can experience discomfort, for example, pain during the night, and that makes his sleep bad. And postsomnic insomnia, this is early awakening, usually due to depression, and also, you know, some elderly people, they also wake up very early. Yes, your grandmas and grandpas, maybe they live with you, and when they wake up in the morning, they make different sounds doing their everyday routine and making discomfort for other members of the family. So this is postsomnic insomnia. What are the endogenous regulators of sleep? They are different mediators in our CNS. For example, serotonin is responsible for induction of sleep. One very important thing is melatonin, which is responsible for synchronization of sleep phases, that fast, rapid eye movement sleep and slow sleep. Then gamma-aminobenzoic acid, GABA, encephalins, endorphins, delta sleep peptide, histamine, acetylcholine, dopamine, and adrenaline, they also play some roles. And there are target structures of our brain which are responsible for the sleep, in which those mediators work and play their roles. They are synchronizing structures in the reticular formation. The thalamus, the hypothalamus, they are responsible for inducing sleep. And also we have desynchronizers, which are responsible for wakefulness in the rostral part of the reticular formation. Well, when we administrate the hypnotic drugs, what do we want from them? We want from them to have the ability to introduce sleep in sufficient depth and duration quickly. Also, the ability to maintain normal physiological sleep structure. By the way, what does it mean, normal physiological sleep structure? It means that those phases of rapid eye movement sleep and slow sleep, this ratio should be normal that we have in physiological condition. And if you remember, I told you that it should be the ratio of 1.5 hours of slow sleep to 20-30 minutes of rapid eye movement sleep. So this we call the physiological sleep structure, okay? It shouldn't be changed. Okay, of course, we want less side effects like respiratory and vasomotor center depressions, the lack of after effects, weakness, drowsiness. These are effects which patient can have after he wakes up in the morning when he uses these drugs. The lack of cumulation, if you remember from general pharmacology, this is the accumulation of the drug or effects in the body. And also we want no addiction or drug dependence or habitation. Well, to tell you the truth, almost no hypnotic drug has such a good list of properties, because there is no ideal hypnotic drug. Well, what are the hypnotic agents which are used today? They are barbiturates, benzodiazepines, ethanolamines, aliphatic derivatives, and also cyclopyrrolones and imidazopyridines. Here they are placed in the order of their occurrence, from the oldest to the newest. But it doesn't mean that we don't use those. Sorry, we don't use those which are older. No, we use them all. Maybe sometimes more, sometimes less. But benzodiazepines, I would say that they are quite often used today. Okay. Here is the list of some hypnotic agents. Benzodiazepines and barbiturates and others. I don't really want to read them, so you can make a screenshot and read them yourself without my help. Actually, these are only names. For us, more interesting is the mechanism of action. This is much more interesting, and I will draw a picture even for you, a scheme. I will now look if I have that scheme in my presentation already, but I will not find it. So firstly, we will talk about benzodiazepine receptor. Here I'm looking for the scheme, but no, I will have no scheme. So I will do it for you right now. I will make this picture for you. So firstly, we should imagine that we have the gamma amino barbituric acid receptor. Actually, this is a kind of complex receptor which has several parts. It has 3 parts at least, but in the middle of this receptor, which consists of 3 parts, we have the special channel. It's the chlorine channel. The channel that can be opened, and the chlorine ions can come inside the cell through these channels. The receptor, as I said already, It is not a simple structure. It is a complicated structure which has 3 subunits. It has 3 subunits. Okay, there's subunit 1, subunit 2, and subunit 3. Okay, these are subunits, and this all complex, it's a GABA receptor, gamma aminobarbiturate acid receptor. But what are these subunits? Okay, let this be the GABA subunit itself, GABA receptor, GABA A receptor subunit. And these 2 subunits, they are sensitive to the drugs, a benzodiazepine receptor and a barbiturate receptor here. But you see that these all 3, they are parts of one big complex, yes? Okay, they are connected strongly with each other. The benzodiazepines are connected with GABA receptor, and barbiturates are also connected with it. So what happens when the drug affects on one of these types of receptor? Okay, for example, we have the drug of the benzodiazepine group. Of course, it can bind with benzodiazepine receptor. So we have a drug affecting on benzodiazepine receptor. What it makes? It actually activates this receptor. And activation of this receptor activates then the gamma aminobutyric acid receptor, GABA A receptor. How it activates? Not just directly. It makes the receptor more sensitive for the natural stimulant gamma aminobutyric acid. So this is GABA A receptor. I forgot to mention in the beginning. GABA A receptor becomes more sensitive with the help of stimulation of benzodiazepine, becomes more sensitive for the natural mediator gamma aminobenzoic acid. So this is our natural CNS neurotransmitter which has the inhibiting function. Okay, now your GABA A receptor is much more sensitive to gamma aminobutyric acid. It can bind better and stronger to this receptor. Well, in natural condition, gamma aminobutyric acid, of course, also can bind to this receptor, but with the help of stimulation of benzodiazepine, this binding of gamma aminobutyric acid to its receptor becomes much stronger and maybe longer even. So stronger binding, better binding will lead to better effect of this gamma aminobutyric acid, of course. Well, what happens next? Stimulation of GABA receptor opens the chlorine channel. What does mean open the chlorine channel? Now the chlorine ions from the outer space, from the intracellular space, they can freely go inside the cell through this chlorine channel. Okay, so we will have the chlorine influx to the cell on which it affects. We remember that chlorine has minus charge, and when chlorine goes to inside the cell, we will have more negatively charged ions inside the cell. What does it mean for us? We should remember from the normal physiology that scheme of action potential and rest potential. Yes, if in the rest our cells have potential like -70, for example, yes, so when we have the influx of positive ions, for example sodium, the potential will grow. Видите, it grows. Okay, but when we have the influx of negative ions like chlorine, it goes down because negative charge, so less potential, so our potential comes down, and we call it hyperpolarization. So you see the potential of the membrane becomes hypernegative, much more negative than it could be. Okay, well, this process is hyperpolarization. What does it mean for us? When we have such low action potential, it cannot reach the critical level of depolarization. You remember what is it? Critical level of depolarization. Yes, this is the level of depolarization which should be reached to get the action potential, to have the activation of the cell. But our level, due to influx of chlorine negative ions, for our level action potential is impossible. You see, it is far away, yes, from the line of action potential. So for this cell, action potential is impossible. That means that cell cannot excite. And if the cell will not excite, so it will be calm, it will have the rest potential, and it will not be awake. So for us, this is good because we want our patient to sleep. Yes, so this is obvious, there is a connection. The same happens when we have the drug effecting on barbiturates. Almost the same, because again, barbiturate receptor will be stimulated by the drug, then GABA receptor will be stimulated, become more sensitive to the GABA. Again, the same effect, gamma-aminobenzoic acid will better bind and chlorine will come inside the cell. Okay, finally, like the mechanism is almost the same, but what will be the difference? In case of barbiturates, there is a longer time of opening the chlorine channel. Longer time, yes. So the channel of chlorine will open and it will stay open for the long time. In case of benzodiazepine stimulating, it will be more frequency of opening of this channel. So it will not be opened for the long time. It will be opened for the short time, but frequent. 1, 2, 3, 4 times. Frequency. I guess that you understand. But the mechanism in general is the same. Chlorine channels should be opened and chlorine should come inside the cell. Finally, the result will be almost the same, but to tell you the truth, barbiturates will give you the stronger action according to the longer time of opening the channel of chlorine. Okay. If our cell is not excited, so of course release of excitatory neurotransmitters, activating neurotransmitters will be also reduced. Yes, less excitation, less activating neurotransmitters. So this will lead to the inhibition of CNS activity. The inhibition of CNS. Okay. What else I wanted to tell here about those release of excitatory neurotransmitters? Yes, they are acetylcholine, glutamate, and asparginate. These neurotransmitters, they have opposite effect. They activate the positive ions. So in case of our problem, when we want our cells to calm down, we don't really want the positive channels open, we want the negative channels to open because we want the hyperpolarization. So these channels, sodium, potassium, calcium, they should be blocked because it will be sensitive for us to stop the action potential of the cell. So acetylcholine, asparginate, and glutamate, they are activating, we will block them, and the ion channels like sodium, potassium, calcium, they will be also activating, so we also will block them. And our favorite chlorine channel we will open. Well, the spectrum of pharmacological activity of benzodiazepines has effects like sedative, so this is calming down the patient. Next, hypnotic, making them sleep. Then anxiolytic, what does it mean? It is when the patient has anxiety, like he's worried about something, or maybe he is afraid about something, so these effects also will be reduced. Anticonvulsant activity, this is reducing the tone of muscles in case of seizures. Maybe it will be the use in epilepsy, for example. What about the central muscle relaxant action? This is, it has a little bit in common with the anticonvulsant activity. We can use it if we have, for example, muscle pain, yes, to relax them. And amnesic action, of course, this is the side effect because patient can lose memory. They can forget about what happened to them before they have used this particular drug. So it is one of the side effects. Okay, the characteristic of barbiturates according to duration of action. Well, here I don't really want to erase that beautiful picture that I made for you, but I have to do that. So I strongly believe that you have made a screenshot, so erase that. Okay, barbiturates can be ultra short. Ultra short action lists only 30 minutes. Well, it is very low actually. And the drug is thiopentol sodium, and why we can use it. This is not enough for us to make patients sleep, yes, because for sleeping we have more time. So our indication is the induction to the general anesthesia. 30 minutes for us, it's enough to calm down the patient before he needs to make a surgery, operation, and before the general anesthetic effect. So this can be the indication for the ultra-short drugs like thiopentol sodium. Shortly acting drugs like ethyminyl sodium last for 2 hours and used for presomnic insomnia. So presomnic insomnia, when for you it's just difficult to fall asleep, yes? And if you have 2 hours of action of this drug, this is enough for you to fall asleep and then sleep the whole night. That. And talking about the medium barbamyl and long like barbital and phenobarbital, they are used for other types of insomnia like intrasomnic or postsomnic insomnia. Okay, to tell you the truth, they can even they can even last for more time. Well, barbiturates. I already told you that it has the effect of enhance the inhibitory effects of gamma-aminobenzoic acid in the central nervous system by affecting the barbituric receptors, yes, then increasing the GABA receptor sensitivity to the gamma-aminobenzoic acid, and that activates chlorine channels, yes, and chlorine comes inside the cell. Okay, then what else? It inhibits the release of activated neurotransmitters. Of course, we don't need the glutamic aspartic acid because they activate the CNS, so we inhibit them. Also, it suppresses the system of wakefulness in the reticular formation of the midbrain, and they inhibit the hypnogen area of the brain, rapid eye movement sleep. Actually, this is not very good because it makes non-physiological ratio between slow sleep and rapid eye movement sleep. Remember, I told you you have to sleep 1.5 hours in slow sleep and then 20-30 minutes in rapid eye movement sleep. So in case of using the barbiturates, rapid eye movement sleep becomes less and slow sleep becomes more. This is not good. This is not physiological for us. And it makes some problems after you stop taking this drug, because when you stop it, everything becomes back even more. So the problems will become even worse after you stop using barbiturates. So that is why they have some habitation, you know, like addiction. But pharmacological spectrum of barbiturates is not only on CNS effects like hypnotic, sedative, hypotensive, and anticonvulsant. Also, it can affect, for example, on liver. Liver, this is very important because it can make the induction of microsomal oxidation of the cytochrome P450. Why it is very important? Because this system, microsomal cytochromes P450, they play a role in metabolism of different drugs and even barbiturates themselves. What happens here? In case of induction of these enzymes in liver, you have much more activity of these enzymes. Yes, if the enzymes are very active, so you can imagine that metabolism will be much faster. Yes, so it will have the faster oxidation of the drugs, and that's why faster elimination of these drugs from the body. Yes, so you can imagine that you take barbiturates, they go to the liver, enzymes are much more active, they enhance the oxidation, and they make faster elimination of these barbiturates. So what happens? After some time, there will be not enough dose of barbiturates to make the effect. And actually, this makes a problem of tolerance to the barbiturates. And also other drugs which undergo the oxidation by the system, they also can suffer. What we can say about the effectiveness of dose effect dependence of the hypnotic drugs? The effects from the low dose, they start with sedation, calming down the patient, then our favorite sleep effect, and then toxic effect like coma and death. So coma, we remember that it is the condition in which patient cannot wake up, but he's still alive. And death, everybody knows what is it, death. Okay, so due to these graphs, you can see that barbiturates and benzodiazepines, they have different dose effect dependence. Yes, absolutely different. In case of barbiturates, this is much easier to how to say, to overdose the drug that much to lead the toxic doses, to reach the toxic doses. Yes, so you see, the more dose you give, the faster effect grows of the barbiturates. And in case of benzodiazepines, the graph is a little bit different. So you take a normal dose of barbiturates, which gives you sedation, a little bit more, it gives you sleep, then you overdose like 5 times, you have coma, and overdosing in 10 times can already lead to death of the patient. By the way, this effect was commonly used by suicide committers because taking a lot of barbiturates gives a highly toxic effect. Talking about the benzodiazepines, you see that graph is much more mild. Yes, it's milder. And by increasing the dose 5 times, you only reach the sleeping effect. And then you can increase more and more. And it is quite difficult to reach the coma condition. Well, of course, this line is not correct. Maybe if you overdose so much, you can get to the toxic effects. Of course, you can do that. It doesn't mean that you will use benzodiazepines without any risks. Yes, there is a chance of toxic effects of benzodiazepines, but in comparison to barbiturates, you can see that risk is much lower. So benzodiazepines are considered to be safer than barbiturates, and they are better used and more commonly used. Well, I also wanted to tell you about one more group of the drugs, which is non-benzodiazepine drugs. Non-benzodiazepine, it means that the chemical structure is different. It's not the same. It doesn't have that benzodiazepine rings, and the chemistry of these drugs is different. They can be also called Z drugs, like zolpidem and zopiclone, because their names start with Z. So these drugs are much safer than barbiturates and benzodiazepines but they actually mechanism is the same as in benzodiazepines. They affect the benzodiazepine 1 receptors, one of the subtypes of benzodiazepine receptors, and these drugs have less side effects. They can also stimulate the gamma-aminobarbiturate acid receptor, which leads to opening of chlorine channels. Again, this hyperpolarization, yes, less action potential in the graph. So patient will sleep, yes, but effects are mild. So patient will sleep, but he will not have coma, he will not have death, he will not have after effects. When he wakes up in the morning, he will be awake, he will not feel weakness and dizziness and so on. And also, what is very important, these drugs, they help to keep the normal ratio of phases of sleep. I mean, slow sleep to rapid eye movement sleep. These two phases of sleep will be normal, 1.5 hours of slow sleep to 20-30 minutes of rapid eye movement sleep. Okay, and the next disease which we are going to talk about is the Parkinson disease. This is the defect of dopaminergic neurons in the basal ganglia and substantia nigra of the midbrain. Okay, we don't actually know why this disease happens, but we can find what happens in this disease. Parkinsonism, this is a pathological condition of the central nervous system accompanied by disorder in extrapyramidal system effects. Extrapyramidal system, it's a structure in the brain which is responsible for the movement of your skeletal muscles, for the control of their smoothness and so on. So what are the symptoms? Rigidity, increased muscle tone, tremor, involuntary trembling, and hypokinesia, stiffness of movements. How we can know that our patient has the Parkinson disease? I'm showing you in the video that he has tremor in his hands. Hands are shaking, head is shaking like that, or maybe like that, but head is shaking all the time. And not only head and hands, maybe the whole time. So shaking is one of the obvious symptoms. What is one more symptom of this is that those patients, they have the hyperactivity of salivary glands. They have a lot of salvia in their mouth, so they have to use the napkins, am I right? Is the things that you can use to remove the extra salvia from your mouth. So this makes quite a big discomfort for their everyday life, and you can find out that those patients have those symptoms very, very often. Okay, so Parkinsonism can also be not just disease. Yes, the Parkinson disease is the initial condition, but also we can have the symptomatic forms of the drug syndrome. What does it mean? It means that sometimes when the patient had no Parkinson disease, but we gave them some drugs which are provoking those dopaminergic pathology, and we can lead to Parkinson syndrome. So when he stops the intake of those drugs, his Parkinsonism stops. We will discuss such drugs in next topic. Ways to restore the balance of mediators in the CNS. So as I told you, we have the problems in dopaminergic process. So what happens in the brain when we have less dopaminergic activity? I can make a picture. I will now make a picture for you with the balance of neurotransmitters in the brain. In our CNS, we should have quite enough activating neurotransmitters and inhibiting neurotransmitters. Why? Because they can make a balance for our body not to be too much excited and not to be too much relaxed. Yes. So in normal condition, we have red activating and blue inhibiting neurotransmitters in the balance. Yes, so we have 3 on the one side, 3 on the other side. This is just a scheme, but you can see that the same amount, more or less same amount, yes, of activating neurotransmitters and inhibiting neurotransmitters. But what happens when we have less inhibiting neurotransmitters? You see, now you don't have the balance, and our situation becomes like that. We have a lot of like heavy activating neurotransmitters and not enough inhibiting neurotransmitters. That's why we have the Parkinson disease. A lot of activation, that's why tremor, that's why rigidity, that's why high muscle tone, and so on. And also activation of the salivary glands. This is also the effect of too much activating neurotransmitters on the background of not enough inhibiting neurotransmitters. Yeah? So dopamine in this case, I mean directly in movement of the muscles, play the role of inhibition. Okay, so what should we do to make the situation better? We should restore the balance of mediators of the CNS. Yes, so if we have that bad situation with the balance, we have a lot of active neurotransmitters and we don't have enough dopamine, which is inhibiting neurotransmitter in this case. So I cannot move those pictures, so I will now draw the new one. So we have a lot of activating neurotransmitters and we have less dopamine, which we should restore actually to stop our Parkinsonism symptoms. I cannot erase those blue and red. Okay, what should we do? We can take the drugs like amplification of dopaminergic process. You see, if I put more dopamine in this side, it will be better because it will make again the balance, 2 on the one side, 2 on the other side. And for that directly we have those drugs like levodopa, Necom, and Medopar, which will directly provide the more amount of dopamine. Also, we can decrease the inactivation of dopamine by inhibition of MAO-B. What is it, MAO-B? This is the enzyme. It's the enzyme which normally, I mean physiologically, is responsible for the breaking down the dopamine. Yes, our natural dopamine. So if I use the silagilin drug, I block this enzyme, so it will not break down the dopamine, and that's why dopamine will increase. So again, on this place, this blue dopamine will increase. Yes, again, our balance will be restored by this help. Okay, this is our variants how to increase the level of dopamine. What else can we do here? We can enhance the dopamine release and inhibition of the dopamine reuptake with the help of the drug amantadine. If in the previous slide we reduce the breaking down of dopamine by silagilin, so now we can also increase the release of dopamine by amantadine. Now I will draw the picture of the neuron in which we can see what is it release and what is it reuptake of dopamine. So if this is a neuron, this is a vesicle with dopamine inside, yes. So dopamine can go out and accumulate here, and also it can come back. Yes, this is reuptake. So if you stop the reuptake of the dopamine into the neuron, what will be? No reuptake, so dopamine stays in the synaptic cleft, and also you increase the release, so you will have more and more dopamine, which can actually affect of stimulation of dopamine receptors. And also we block NMDA receptors. Why? Because NMDA, they are red ones. Yes, they are on the other hand, they are activating neurotransmitters, so we want to block them to have less effects here on this place. Because NMDA, this is an activated neurotransmitter. So dopamine we will enhance, dopamine we will stimulate, and NMDA and methyl D-aspartate receptors we will stop. So you see, again, we have the balance between the dopamine and activated neurotransmitters. So this is amantadine effect. Okay, what else? We have also direct stimulating of D2 dopamine receptors. Yes, what does it mean? It means that actually, like in true situation, there will be no more dopamine in the brain, but it will be like a simulated activation of dopamine receptors, because the drug will play a role of dopamine for the CNS of our patient, like he has more dopamine. But this is not dopamine, this is bromocraptine. But it doesn't matter for our brain. The brain has activation of receptors, so the brain feels like it is okay. Okay, I have the balance. And one more effect, blocking the central choline receptors. Acetylcholine is on this side, so it is an activation. So we want to block it to, again, reduce the amount of activating neurotransmitters. And trigexiphenidil or cyclodol will help in this situation. So now we will go to the next disease, epilepsy. Epilepsy, this is an interesting chronic progressive disease with recurrent seizures, which are accompanied by motor, vegetative, and mental disorders. Actually, we don't know why epilepsy happens, but we have a theory. We have a theory which tells us that in the brain there is a group, like an area, the group of pathological neurons. What is pathological about those neurons? They have pathologically high permeability. They have pathologically high permeability. Permeability for different ions, for sodium, for calcium, for potassium, chlorine, and so on. So what will be the result of this pathologically high permeability? If a lot of sodium, for example, comes inside these channels, what happens? The action potential will grow. No, I mean the potential of the membrane will grow. A lot of sodium comes inside. Sodium, as you remember, has the plus charge, yes? So the pathologically highly permeable membrane lets a lot of sodium inside, and not only sodium, calcium, also potassium can be, and this all leads to action potential. Again, we remember our potential from normal physiology, so the cell gets excited, the cell gets activated, and as it is pathological, that means it gets activated in those conditions when it doesn't need to be activated, yes, and after it spreads these signals around, yes, not only these neurons, but all the brain it can occupy, we can say. Yes, it spreads around and gives this excitation to the cells which are surrounding. So the surrounding areas will also be activated, they will also have action potential, and this spreading of the excitation will lead to epilepsy. This will lead to the motor, vegetative, and mental disorders of the patient, because the structures which should not be activated in that situation will become activated. So what we want to do, we want to stop all this process by stopping these pathologically high permeable neurons. Because when we stop this place, others will also stop. Okay, so this scheme is, you see, it is like in Parkinson disease, but a little bit different, because on the one hand we have activating glutamate and aspartate, And on the other hand, we had dopamine, but in the case of epilepsy, we have inhibiting gamma-aminobenzoic acid and glycine. Lamamine, and they are also inhibiting neurotransmitters. So the reason of the development of central seizures is again disruption of the balance between inhibitory neurotransmitters GABA and glycine and stimulating transmitters glutamate and asparginate. So glutamate and asparginate are too much and GABA and glycine are not enough. So what we will do again? We will do again the same. We will try to make a balance back. Here is the classification of different seizures. Actually, I don't want to read them. You can read them yourself. We can have different forms of epilepsy. Some of them have more seizures, some of them have less, can be generalized and partial, so you will read it yourself. Okay, so what we can do with our pathologically highly permeable neurons? As I told you, they let in too much sodium. They go through the sodium channels, yes? So if you directly block the sodium channels, you can stop that action potential, yes? So this is logical, just direct blocking of sodium channels, no high level of sodium in the cell, no action potential. And for this, we have such drugs as phenytoin, carbamazepine, lamotrigine, topiramate, and valproate. By the way, of course, this is not the only one mechanism, and some drugs, they can have combined mechanisms affecting not only on sodium channels. For example, valproates, we can find them with sodium channels and potassium, and calcium and many other different mechanisms. Okay, but in general, you understand, yes, that sodium channels, if you block them, no action potential, no epilepsy. Okay, what else? We can also block the calcium channels because calcium, it is also the activating positive ion, yes, 2+ it has charge, and by blocking them with the drugs ethos, zuximide, and valproate again, and topiramate, you again reduce the excitation of the cell and you reduce the action potential. Okay. Here you can see that valproate and topiramate has both mechanisms of sodium channel blocking and calcium channel blocking. Don't be surprised with that, because these drugs, they really have the combined mechanism of action. And that's why, by the way, they are very good in treatment of epilepsy. Valproate is one of the favorite. Okay, what else? As we said, the GABAergic system plays the role of inhibitory system in case of epilepsy. So we need to activate it to restore the balance again. Yes, you remember that. So which drugs? Already known benzodiazepines, already known phenobarbital, yes, barbitals and benzodiazepines, clonazepam also, and our favorite valproate, and also vigabatrin and gabapentin, and topiramate. So these drugs will restore the balance. And on the other hand, you remember that we have too much activating, like glutamate and aspartate. So we want to decrease them, decreasing the release of glutamate and blocking the receptors. If we decrease the release of glutamate and also our activating aspartate, asparginate, we will block the receptors of them. So again, less activation will be and less active action potential. So that is how we will again restore the balance. The drugs which can do that is phenobarbital, lamotrigine, and topiramate. Okay, well, this is it. Thank you for your attention. See you on the next lecture. Goodbye.